Good evening, all of you. I hope I'm audible and visible. Kindly confirm in the chat box once. Hi, Shiv. Thank you so much. I'm good. I'm good. So, welcome to this one more session on Meded Clinics. So, here today we are going to discuss about dermatology again. I'm Dr. Jazeer, your dermatology faculty at PW Meded. So, what is the topic that we are going to deal today? Any idea? I guess all of you know the topic. It's a very common topic, a disease or a clinical entity which can be experienced by everyone, isn't it? So the topic that we are going to deal with today is the approach to acne and its variants. Like all of us, we I would say that it is not just a few patients, but everyone has experienced these pimples over the face anytime in their life. And most commonly, when does anybody get these kind of pimples? Is it during childhood, adolescence, adulthood, elderly population? So when is it most common? When it comes to having an acne or pimples, the most common age group is usually the adolescent period or the puberty period, right? So today what we will try to do in today's session is we'll try to understand that whenever a patient is coming to you with this common complaint of a pimple or an acne over the face or at the trunk, then we'll try to understand what should be our approach, how are we going to examine the patient, and how are we going to classify this kind of an acne vulgaris, and finally how do we manage it as well. So that is the entire plan of today's session. So that is the learning objective which I have already discussed with you. So during this one, we will not only emphasize on the clinical scenario, we'll also try to understand what is the reason why somebody develops an acne vulgaris, what are the pathology or etiology that is associated with it, and we'll definitely try to understand the various clinical entities or the diseases that is associated with acne, and then we'll dive into the management as well. Clear? So now let's move. So let's see what is our approach going to be. So let's start with the basic introduction. Like whenever we talk about any disease, this disease we should be able to give an introduction, right? So what is acne? Is it considered to be a infection, or is it considered to be any autoimmune condition, or is it any inflammatory condition? So what is acne? So acne, this is a chronic inflammatory condition of the pilosebaceous unit. Pilosebaceous unit. Now, what is a pilosebaceous unit? So, pilo means hair follicle. Sebaceous, as the word says, sebaceous means sebaceous gland. So, what is involved in the etiology or this disease of acne vulgaris is a pilosebaceous unit, where a hair follicle is involved as well as a sebaceous gland is going to be involved. Clear? And as I have already told you, that 85% of the cases are seen during puberty. Okay, that is why this acne that is seen in puberty or in adolescence is going to be very common. So that is going to be 85% of the cases are seen in puberty. And what happens is, along with that, different age groups can also be involved. Various age groups can also be involved in this. So why do I say that various age groups can be involved? Is because there is a clinical entity which is called as neonatal acne. There is a clinical entity which is called as senile acne. So neonatal means it is seen in neonates. Senile means it is seen in adults, isn't it? Hormonal acne is there. So all those different clinical entities are also there. So this is the basic introduction. So we are going to deal about a chronic condition of the pilosebaceous unit. So now let's see what is the pathophysiology of the acne. So what are the reasons why somebody can develop acne? The first one is a overgrowth of a bacteria. Now in the chat box, can you let me know that what is the overgrowth of which bacteria that can cause acne or a pimples in our face or in our trunk. So is there any bacteria that is implicated in this pathogenesis of acne? If yes, what is the name of the bacteria? Anyone in the chat box? Yeah, Propionibacterium acnes. Very good, Shiv. So this is called as Propionibacterium acne, isn't it? So this Propionibacterium acne, this is also called as, what is the another name? So this can also be called as the QT bacterium. This is also called as the QT bacterium acne. So this is a bacteria, the overgrowth of which can lead to the pathogenesis of acne. The another one that is very commonly implicated is, just imagine करो कि there is a patient who has got acne. क्या उनका skin dry हो सकता है, या is it a oily skin that you expect? Oily skin is more prone to acne, या dry skin is more prone to acne? So what is it? Anyone in the chat box? I'm just looking into the comments into the chat box now. So यहाँ पे, as you know, yeah, this is going to be oily skin. So this one we call it as seborrhea. So what is the meaning of seborrhea? It means excessive sebum production. So when there is a excessive sebum production, so this can lead to oily skin. Okay, that can lead to oily skin, and this oily skin can in turn lead to acne vulgaris. It can in turn lead to acne vulgaris. And the next one is follicular hyperkeratinization. So that is another reason why a patient can develop acne, because what happens with the follicular hyperkeratinization, there is a blockade of the pilosebaceous unit. Okay, that is the next one. And finally, there is some inflammation also. So there is going to be some inflammation as well, because of which, yeah, because it blocks the about the duct. Very good, Shiv. So that is also right. And then finally, there is going to be some inflammation as well. So when there is inflammation, when there is neutrophils, cytokines, T cell, all those activation, this can also lead to the pathogenesis of acne. So please remember these four features. One is overgrowth of a bacteria. The second one is going to be increased oil production. And then the next one should be follicular hyperkeratinization, and the last one should be inflammation. So all these are the reasons behind acne vulgaris. So now let's come into clinics. Now, just like how we do it usually in med clinics, the same way, now you need to imagine that you are the dermatologist here, and you are getting a lot of patients who are coming to you for the management of their acne. So whenever you get any patient with these pimples over the face, the first thing that you as a good physician has to do is to identify the lesions. आपको very closely examine करना पड़ेगा कि कौन सा lesions है. Are those comedones? Are those papules, pustules, etc.? So this is what has to be firstly identified. So first one, I will just mention कि non-inflammatory lesions. Now, what are the non-inflammatory lesions that you can see in acne vulgaris? अभी मैं zoom करता हूँ ये first image. अभी ये first image में, what is the color that strikes you all of a sudden? What is the color that strikes you as soon as you see this image? कि आपको red easily दिख रहा है या फिर black color easily दिख रहा है? What is it? Obviously, for me, all these black spots are getting more visible. Okay? So what are these now? So these are called as black heads or open comedones. These are called as black heads or open comedones. So this is the first type of lesion that all of you will have to, examine and understand in your OPD. Okay. These lesions are called as blackheads or open comedones. Now, why is this lesion turning black in color? Anybody can you answer why these are black in color? Yeah, why do we call it as open comedones? So both these are related. Open is related to black. क्यों? ऐसा क्यों हो रहा है? Because when you closely examine, you can see that all these lesions, they have opened up. So once these lesions have opened up, there is an oxidization reaction that is happening. And because of this oxidization reaction, what is happening? The color is turning black in color. So open matlab oxidization, and oxidization matlab black in color. So clear? So very good. So I got the answers in the chat box as well. So this is due to a oxidization reaction. अब देखते हैं what is the second one. Now I'll just zoom the second image for you so that all of you can see this. Now in the second image, what do you see? Are these lesions open or closed? ये काफी intact lesions है. It is not open, isn't it? These are intact lesions. So this one, we call it as whiteheads, or we call it as closed comedones. Closed comedones. So is it easy? So whenever you get a patient, just examine. So once you examine, if you find the lesions have opened up and there is a change in color, ये हो गया open comedones या फिर blackheads. If it is intact, that is going to be closed comedones, or it can be called as a whitehead. And what are these two type of lesions? These two type of lesions are called as non-inflammatory lesions. अगर non-inflammatory lesions है, then there should be inflammatory lesions also. Agree? अब देखते हैं इन्फ्लेमेटरी लीशंस कैसे होते हैं. ओके, सो नाउ वी आर गोइंग टू टॉक अबाउट इन्फ्लेमेटरी लीशंस. अब आप एक पेशेंट को एग्जामिन कर रहे हो और आप यू आर नॉट एबल टू सी दैट देयर इज एनी कोमिडोन्स. कोमिडोन्स नहीं है. इंस्टेड ऑफ कोमिडोन्स you are seeing these kind of lesions. Now what are these kind of lesions? I can say that okay, these are comedonal. Okay, these are comedonal acne. ये कॉमिडोनल एक्नी के साथ what is the other thing that you see? ये जो raised lesions हैं, all these red color raised lesions, what do we call for these raised lesions? These are papules, right? Any elevated lesion less than 1 centimeter in diameter, we call it as a papule. So this can be papular acne. And in case if all these things are going to be your differential diagnosis of the day. Okay? We'll talk about it. In case the patient is coming to you, काफी ज़्यादा lesions है face में, but along with these lesions over the face, you can also see कि यहाँ पे और यहाँ पे all these lesions, there is some pus within this lesion. So this can be considered to be a pustular acne. So this is also another one. So papular acne हो गया, pustular acne हो गया. So all these are considered to be inflammatory type of acne vulgaris. So not just that, sometimes you can see that the lesions have become enormously big. So what are these? What are these? ये कोई पैप्यूल है या फिर कोई पस्ट्यूल है या पैप्यूल एंड पस्ट्यूल से भी बड़ा है ना. So these kind of very very big lesions that you see over the face. So what are these called as? Anybody? So this one is called as nodulocystic acne. So these are called as nodulocystic acne. Kyunki the lesions are big. So since it is bigger than a papule, we call it as a nodule. So there can be nodulocystic acne. So all these are the inflammatory type of acne. Clear? So this nodulocystic acne, when you read your textbooks, you can see multiple names. So this is also called as acne. Anyone? What is the name of nodulocystic acne? Any idea what is it also called as? This is also called as acne conglobata. It is also called as acne conglobata. Clear? And this type of acne, this is considered to be severe acne. So this is considered to be a severe acne. So these are the various types. So in case whenever you see a patient of acne vulgaris, try to differentiate whether ये inflammatory lesions है या फिर non-inflammatory lesions है. Many times you can see a combination of both. Okay, non-inflammatory lesions can also be present. Along with that, inflammatory lesions can also be present. And the type of lesions that we need to see are the comedonal acne, whether it is a blackhead or a whitehead, or it can be a papular acne where the lesions are primarily papules, or it can be a pustular acne where the lesions are primarily a pustule. Sometimes very large lesions do appear, and these large lesions are called as nodulocystic acne or acne conglobata. Okay, so that is all about these type of acne. And after the inflammatory and the non-inflammatory type of acne, there is also some other variants as well. Just a minute. So there are other variants as well. Now, what are the other variants? The first other variant, I would say that this is going to be acne fulminans. Because what happens in acne fulminans is, in acne fulminans, the patient can present to you with very large lesions. So what do you mean by very large lesions? The large lesions can be nodulocystic lesions. But along with that, the patients will also have some systemic symptoms as well. Systemic symptoms. Because whenever you get a patient with acne vulgaris, he is not coming to you with fever. He is not coming to you with tiredness and many other systemic symptoms. Whenever a patient is coming with a very large lesion along with systemic symptoms, then you need to keep this thing in mind. That is going to be a acne fulminans. It is going to be acne fulminans. The other variants that can be, it can be a drug induced acne, can be drug induced acne. So in your clinical examination as well as in history taking, you will have to ask the patient, are you taking some drugs which has caused this acne? Now, can you tell me any drug which can cause acne vulgaris? Let me say that a patient is taking, he has been diagnosed of pulmonary tuberculosis. While the patient was undergoing a treatment for pulmonary tuberculosis, the patient is developing a lot of lesions over the face, and you examine and you get to know कि हाँ ये drug induced acne हो सकता है. Now tell me कि ऐसा कौन सा anti tubercular drug है which can cause drug induced acne. So yeah, so it can be seen with many, isn't it? So a lot of drugs can cause this kind of a drug induced acne, but as you have rightly said, isoniazid can be one. And steroid tablets, like the patient is taking prednisolone for a longer period of time, that can also cause acne. So steroid tablets can also lead to acne vulgaris. So a lot of medications can also lead to acne. Sometimes in the case of a patient who is having seizures, okay, one if they are taking anti-epileptics, they can also present to you with acne vulgaris. That is also a very common thing. Some psychiatric patients, like who are taking lithium and all, so they can also cause. So patients who are on lithium can also show drug induced acne. So all these are going to be different types of acne. Now if I just go to this image now, if I am just zooming this image, what is the peculiarity of the acne that you can see in this patient now? Can you see this image? Can you see that there are acne lesions over the jawline? Okay, so whenever you see that there is a young female who has come to you with complaints of acne, and you find that the lesions are mostly present over the jawline, then which type of acne can it be? Anyone? Beard area acne, not the actual answer. So this one, especially in females, please remember that whenever you find that the lesions are present over the jawline, so this can be due to hormonal acne. Okay, that can be due to hormonal acne. So another one is going to be hormonal acne, where the lesions are usually along jawline. Okay, so in such patients, what are you supposed to do? You will have to check what is the reason why somebody is having this kind of thing. It can be due to androgen excess. It can be due to androgen excess, or it can be due to something called as PCOS. So why is it PCOS? That is polycystic ovarian disease. So you will have to check the patient for FSH, LH and all, because this is mostly related to hormones. So this is going to give you a clinical clue that the patient, especially in females who are having a acne around the jaw line, this can be due to some hormonal imbalance as well. So Samantha, I hope it is clear. So whenever you are suspecting some hormonal imbalance, so you can see that the lesions are present over the jawline, and you will always investigate the patient, like why. You will be asking the patient whether the periods are regular or not, whether there is a history of polycystic ovarian disease. You will also check the patient for FSH, LH and all, if there is any androgen excess or not. So that is how you will be able to reach out to a better diagnosis and a better treatment. Clear? Okay. So that is all about this type of acne. So now let us see what are we going to do. So now we are going to decide the acne. Like initially we decided ki acne, a patient has come to you. What are the first thing that you are trying to do? You are trying to see कि कौन सा lesions है, inflammatory lesions है या फिर non-inflammatory lesions है या फिर combination of both. जैसे कोमिडोन्स हो गया, पैप्यूल्स हो गया, पस्ट्यूल्स हो गया, नोडुलोसिस्टिक एक्नी हो गया. Now you will have to also count on the severity of the disease. Now how do we count on the severity of the disease? Now based on the severity, because initially we were dealing on the morphology, okay, that is about inflammatory and non-inflammatory. So now what we are going to deal about is regarding the number of lesions that is present. So here we can divide the acne into mild acne, moderate acne and severe acne. So now we are going to deal with mild, moderate and severe. So what do you mean by mild acne? So mild acne means, imagine that you have a patient who has got some comedonal acne. So when a patient is having some comedonal acne along with few papules or pustules, so this we can classify as a mild acne. So based on the lesions itself, comedonal acne ho gaya, papules and pustules ho gaya, and there is no scarring. So there is no scarring as well. No scarring. So this one is called as mild type of acne. Whereas when does the acne becomes moderate acne? Moderate acne when you don't see any comedons anymore. You find only inflammatory lesions here. So what are the kind of inflammatory lesions that you see here? Is going to be again going to be some papules, or it can be some pustules, isn't it? So when you see some papules and pustules along with some nodules, okay, there is some nodules along with a mild scarring. Along with some mild scarring. So along with some mild scarring, this is going to be called as moderate type of acne. This is going to be called as moderate type of acne. Clear? So now we will also see what do you call as a severe type of acne. Now what is going to be severe type of acne? So यहाँ पे, are you going to expect any comedons? The answer is no, isn't it? Are you expecting any type of papules and pustules? The answer is again going to be no. What do you see? Widespread nodules. Widespread nodulocystic lesions will be present, and along with that there would be some deep scarring as well. So when you see all these things, then that is how you will classify it as a severe acne. Okay, in this cases what will happen, along with the face there is an involvement of the trunk as well. Okay, there can be an involvement of the trunk as well. So you can see that those lesions are present over the trunk. So that is how you call it as a severe type of acne. Clear है? So first आपको morphology देखना है, और morphology के बाद you try to classify it. ये mild है या फिर moderate है या severe है. So mild में you always find comedones. Moderate में you mostly find papules and pustules. Severe में you mostly find nodules and cysts, nodulocystic. And in which type you expect maximum scarring? Deep scarring is expected in the severe type of acne. Okay. So now we can also see in your clinic that there are different types of other variation in presentation also. So what is this variation in presentation? Sometimes you can see something like this where a neonate. So this is neonatal acne where a neonate can present to you with multiple pustular lesions over the face. Okay, so that is called as neonatal acne, where a patient can present to you with multiple pustular lesions over the face. The second one is that sometimes, can you see that in this image, what has happened here is, what is the primary skin lesion that you see here? I'll just zoom it for you. So once I'm zooming it for you, you can see that there are multiple pustular lesions. And where is this pustular lesion mostly present? These pustular lesions are present around the nose, isn't it? Around the nasal area and all. So these are sometimes going to be gram-negative folliculitis. Gram-negative folliculitis, where you can see that there are pustular lesions over or around the nasal area. Whenever there are pustular lesions around the nasal area, this can also lead to a suspicion of a gram-negative folliculitis. Then you will have to ask the patient, are you taking some medications? The patient will definitely say कि हाँ मैं clindamycin gel use कर रहा हूँ. Now it is already 6 months. या फिर मैं doxycycline का tablet ले रहा हूँ. It is already 2 months. So when you use clindamycin or doxycycline or any antibiotic tablets or creams for a longer period of time, what happens? There is a disruption of the normal flora, because of which a patient can develop gram-negative folliculitis, because of which a patient can develop a gram-negative folliculitis. So in all these cases, there will be a history of acne which is treated with antibiotics. So in all these cases, there is going to be a history of acne which is going to be treated with antibiotics. Is that clear? Make sense? Okay. So again, some variants. See, whenever you see a patient, someone who is coming to you like this, don't just think that this can be just some pityrosporum folliculitis and all. This can also be acne vulgaris, isn't it? So this one we also called as a truncal acne. So this can be a truncal acne. Okay. See, Mohammed Bassam, I believe that there is a short handbook of Indian Association of Dermatology, IADVL. So the small handbook is good enough. You get a lot of images, real-time images, and a good clinical approach can also be seen in this handbook. That would be adequate enough for your postings, especially, yeah, especially for your postings. So that is also called this. So this one is also called as truncal acne, because whenever you see these lesions, it is not necessary that you get nodulocystic lesions. You can also get papulopustular lesions also. So sometimes it can be seen over the trunk as well. So even though the face is the most common site, but still truncal involvement can also be seen. Clear? So now let's come into differential diagnosis. Now, when it comes to differential diagnosis, most of the times what happens is a patient coming with lesions over the face, it's very easy to diagnose कि हाँ ये acne vulgaris है. Now the only thing is you need to just differentiate कि ये कौन सा presentation है, ये comedonal है, papule है, pustule है, all those things. But for your exams as well as in your postings, it's very, very important to say the differential diagnosis. Can you tell me some of the differential diagnosis? Anyone in the chat box, please? Some differential diagnosis. Face. First thing what you have to think is, think about the etiology. ये एक डिसीज है जहाँ पे पाइलोसेबेशियस यूनिट इज इन्वॉल्व. Is there any other disease where a pilosebaceous unit can be involved? So think logically. Pilosebaceous unit involvement. It starts with R. Yeah, very good. Acne, rosacea. So I'll just write down rosacea. So whenever a patient comes with a red face or is having some telangiectasia or some papillopustular lesions, this can also be rosacea. So rosacea is one thing that you will have to rule out. But always remember, in when it comes to rosacea, how can we easily differentiate? Remember, no comedones. Okay, no comedones in rosacea. Comedones is only seen in acne vulgaris. ये हो गया एक differentiation, and there would be a very prominent erythema when it comes to rosacea. That is why a patient comes to you with a red face. Along with SLE, you also think about rosacea when it comes to red face. What are the other differential diagnosis? Any other differential diagnosis? एक differential diagnosis मैंने already आपको बताया. That is going to be gram negative folliculitis, isn't it? So gram negative folliculitis, that is usually because of the overuse of antibiotics. Antibiotics. ये हो गया the second differential diagnosis. Any other differential diagnosis? Sometimes you can see when it comes to trunk and all. Okay, agar patient is having some these kind of papular lesion or large nodular lesions over the axilla and all, hidradenitis suppurativa, especially over the axilla. Okay. That can be another one. Another very, very important differential diagnosis that you should not miss, especially in the case of truncal acne and all, is going to be pityrosporum folliculitis, isn't it? It is going to be pityrosporum folliculitis. So as the name says, this is going to be a fungal disease, isn't it? This is going to be a fungal disease where we usually can see a monomorphic pustules can be seen. So that is what you can see in pityrosporum folliculitis. Okay? Now, moving further, what should be our clinical approach to the patient? So, as usual, as in any cases, first we will take a detailed history. We'll try to understand ki when did the lesions appear. Okay, the duration of the symptoms, isn't it? The onset of the lesions, the duration of the symptoms, and any other previous history. Previous history is also important because, yeah, previous treatment that is taken, because we will get to know ki patient has tried what all combinations and all, what worked and what did not work in the past. All those things will be done. And after taking a proper history, we will always all go for a physical examination also. So in the physical examination, it is not only the face, you also need to uh, examine the trunk as well, so that you will understand whether there is an involvement of the chest over the back, over the shoulder area. So that gives you a much more easier shortening down on the diagnosis, isn't it? We can also look for signs of, in the physical examination, you can also look for the signs of hyperandrogenism, isn't it? Or hirsutism. So this can also be looked out because as I told you that there are patients like PCOS who can have this thing. Otherwise, hyperandrogenism, androgen excess, may you can have these things. If there is any hirsutism, if there is any acanthosis nigricans, acanthosis nigricans. So all those things can be done, isn't it? Yeah, Shiv, we are giving many more differential diagnoses here, which I highly appreciate. Like for the whiteheads, Milia can be a very close differential diagnosis. Syringoma, which is a benign tumor, can also be a differential diagnosis. See, what happens is syringoma, like instance, syringoma, it is usually seen just below the eyes. Okay, this is the common area where you can find, and you can see that these are some kind of a vesicular kind of a lesions, but not any kind of comedonal lesions. Syringoma. Okay, so that is going to be the first one, and that is usually seen around the eyes. That is the most common site. When it comes to milia, it looks like so many small water drops over the skin, isn't it? So that is again because of not frequently washing the face, because the patient can develop this because of lot of sweating and the sweat being present over the face without washing. So all those things can be a reason for milia as well. But the moment you see multiple comedonal lesions, you'll be easily be able to differentiate between a comedon and a milia and a syringoma. Syringoma ka different, the presentation is much more different. It's much more easier to diagnose. Milia, I agree, it can be confusing with a comedon, but when you see more cases, it is again easier to differentiate. Okay? So I think I have answered the queries in the chat box. Yeah. So I was talking about the physical examination, how it is going to be important. So please make sure that you don't restrict your physical examination to the face, and also examine the trunk as well. And along with that, please try to understand if there is any features of hirsutism, hyperandrogenism, etc., because that will also help you in the overall management. Yeah. So moving further, what are the investigations that you would like to do? So see, in most of the cases, this is going to be a clinical diagnosis, and usually no test is required. That is a usual scenario until and unless you are actually working up for a hormonal workup. Let us say you may have to go for a hormonal workup when you're suspecting a hormonal acne, which I've already discussed about it, especially when you are suspecting PCOS, okay, polycystic ovarian syndrome. And sometimes you feel that the patient is not responding well to clindamycin, or the patient is not responding well to doxycycline and all. You can go for microbiological test, especially when you are thinking about a resistant acne. When you are thinking about a resistant acne, like you have tried different treatment modalities, but still the patient is not responding properly, then you can go for a bacterial culture, a fungal KOH, etc. You can go for a bacterial culture, fungal potassium hydroxide test, etc. So all these things can be done. Okay? So that is how you are going to do this thing, and especially doing a skin biopsy and all is very rare when it comes to acne vulgaris. Clear? Many people come with acne on the trunk, mainly on the shoulder. Is that classical acne due to dandruff? Yeah, so very good question, because whenever that a patient is having seborrheic dermatitis or dandruff, what happens when these whitish flakes they fall over the skin, when there is some whitish flaking over the forehead area, or when there is a whitish flaking over the shoulder area and all, so there is an inflammatory reaction, because of which again you can see a lot of comedonal kind of lesions. That is absolutely correct. So in such cases, what you have to do is you have to go for a proper management of the seborrheic dermatitis. Ab antifungal lotions use karo, and then once you use this antifungal lotions over the scalp as well as over the trunk, what happens, the entire lesions will start disappearing. But this is more kind of a reaction to this whitish flakes that comes out of seborrheic dermatitis. Clear? So now let's talk something about the management of acne now. Okay. So now you have already discussed about some of the approach. You know how to approach the patient with acne, how you have to identify the type of acne, and then you will also grade the acne कि ये mild है, moderate है, severe है. You have decided कि कोई investigations की ज़रूरत है या नहीं. So now when it comes to the treatment part, what are you going to do with the treatment? So the first thing that I would like to add here is, let's talk about general principles. What are the general principles? Like, you can ask the patient to wash the face at least twice in a day. Okay, so washing face at least twice in a day using a mild soap. So using a mild soap or face wash. So all these are very, very important. And even it is also very important that you have to tell the patient to have a good compliance, advise good compliance to treatment. So why should we advise a good compliance to treatment? The reason is, अगर आप डॉक्सीसाइक्लिन का टैबलेट एक हफ्ते के लिए देंगे, so are you expecting any good outcome? या फिर आप क्लिंडामाइसिन जेल यूज कर रहे हो for 1 week or 2 weeks, क्या entire face is it going to clear off and become normal? No. So it is going to be a time consuming process, because usually 8 to 12 weeks is required for a good response. Because 8 to 12 weeks is required for a good response. So we have to ask the patient to follow a good compliance to treatment. And in the diet also, it is better to follow a low glycemic index wala diet. Okay, low glycemic index diet. So having a lot of sugars, a lot of bakery items, a lot of chocolates, so this can even worsen. That is why when a patient of adolescent age group or puberty comes to you, you will have to advise the patient ki cut down on your ice creams, cut down on your chocolates, cut down on the bakery products, because that is also been seen aggravating the lesions. So that is also very important. Oily skin, see, be it a oily skin, but still at least you will have to wash it out twice in a day, and it is better you use a face wash as well. Okay? It's very, very important. So thinking that it's an oily skin and not washing it out properly, it is not going to help you. Okay? So that is about the general principles. And now coming to the treatment. Now treatment, I would prefer to keep it separate for a mild acne, moderate acne, severe acne. So that is going to be the best approach. So always remember, our first line agent is always going to be topical retinoids. Okay. So mild acne matlab kya hai? There is going to be some comedones, there is going to be some papules, some pustules, and there is no scarring. So whenever you get a patient like this, always start the patient with topical retinoids. So this is the first line agent. This is going to be the first line agent. So by any chance, do you remember the examples of any topical retinoids? So topical retinoids, the examples can be adapalene and tretinoin. So adapalene and tretinoin, all these are examples of topical retinoids. So along with that, in case you want to go for a combination therapy for in the cases of mild acne, you can also add benzoyl peroxide to it. So there are a lot of combinations that is available, like adapalene plus benzoyl peroxide, या फिर tretinoin plain is also available. So if you want to go for a combination, then you can try about topical retinoids along with a benzoyl peroxide. The tazarotene, very good. This is a topical retinoid. I completely agree. But tazarotene is used in psoriasis. It is very less used in the cases of acne vulgaris. But you are right if you are answering tazarotene as the topical retinoid. Clear? Now let's go into moderate acne. So what are we going to do with moderate type of acne is, again, we have to stick on to the same. The first line is again going to be topical retinoids. Because you still remember what is a moderate acne? So in moderate acne, what has happened is you see very less of comedones. Now you see more of papules and pustules, and there is some very few nodulocystic lesions, and there is some scarring as well. Okay, अभी तो थोड़ा moderate हो रहा है. So if it is moderate, still we always need to have this topical retinoids. So along with topical retinoids, we can go for a combination therapy. So what is the combination? We were using benzoyl peroxide, right? Benzoyl peroxide. Along with that, you can also add antibiotics. Along with that, you can add antibiotics. It can be either topical or it can be oral. So when I talk about antibiotics, the topical ones that we use are usually clindamycin. So let's say topical ones we use clindamycin. And the oral ones we go for either doxycycline or we go for minocycline, or we can go for a minocycline. So that is how it is done. So it is easy to remember. Mild में topical retinoids plus minus benzoyl peroxide. Moderate में topical retinoids, benzoyl peroxide. Along with that, go for either a topical or a oral antibiotic. So that is much more easier way to remember. अब आ गया the severe one. Severe में क्या दिखता है usually? You can see a lot of nodules and cysts and a lot of scarring. So for such large lesions and all, you are not going to be dependent on a cream. So this is a place where you will be. So no, we don't use anything as such here in acne. So now what we do is here we go for oral retinoid. Can anybody give me the name of an oral retinoid which is actually considered to be the best treatment? Because if you give an oral retinoid, what happens? The patient will show excellent responses in any type of acne, but we don't use it usually in mild and moderate because oral retinoids, they usually come with a bunch of side effects. Okay, very good. The example here is isotretinoin. The example here is going to be isotretinoin. Okay? So in isotretinoin, this usually comes with the side effects. That is the reason why we don't prefer it much in other cases, but absolutely a wonder drug. You start on isotretinoin tablets. The patient, it may take around 3 to 4 weeks till the time the patient may show an improvement. So initially what happens with isotretinoin is you give this tablet, the patient may have a little bit of flare of the lesions. The lesions may increase for some time. But after that, about 2 to 3 weeks, what happens? The patient will show drastic improvements. And the overall duration of the treatment will be somewhere around 3 to 4 months is required for a management of a severe type of acne. Okay, but what are we actually be afraid of? We are actually scared of some of the side effects here. So always make sure you know the side effects while you are prescribing this isotretinoin, because the side effects can be dryness of the lips. That is very common. And dryness of the lips, we are not concerned, है ना? Are we concerned about patient का lips dry हो रहा है? नहीं, क्योंकि हम lip balms, moisturizers use कर सकते हैं, तो वो easily manageable है. But जो dreaded side effect होता है, the most severe side effect that we can expect is teratogenicity. Because when a patient is taking isotretinoin, we have to make sure that the patient does not conceive. Okay? The patient should not become pregnant, because in case the patient becomes pregnant, then what happens? The patient can deliver a baby with side effects. Okay, with side effects. What is it? 1 mg per kg. Always thinking for 200 kg, the dose is still 1. See, Shiv, what happens is we don't go for such heavy doses. We usually start with 0.5 mg per kg. We can increase it up to 1 mg per kg. And usually either a 10 mg tablet is given or a 20 mg tablet is given. That is how it is being done. Because ये जो retinoids है, because of these retinoids, the patient will have a lot of dryness. The patient may complain of deranged lipid profile. All those things can be seen. So that is the reason why we are a little bit cautious, and we don't just directly go into, let's say, 70 mg of isotretinoin in one go. So we just start with 10 mg OD. We can increase it to 10 mg BD, or we can go into 20 mg OD. So that is how we can constantly increase the dosage. Okay, that is how it is being done. So you'll never go for a very high dosage in one go. And every time the patient comes back to you, please ask the patient to come with their lipid profile so that you can see whether their lipid profile is normal or not. You ask them कि कोई dryness of the skin वगैरह है या नहीं. So some patients can also complain of some side effects like depression when they take isotretinoin. So all these things should be in your mind. Clear? Okay. And a few words about some newer treatments also. Some new treatments that is being used, like we are also going for some fruit peelings and all. So this is like chemical peeling can also be done for, that is like salicylic acid peels are present, glycolic acid peeling is there, some lights, some laser and light therapy can be done, like there is a blue light therapy, there is a fractional CO2 laser. So that is all present in the latest treatment as well. Okay. Now, once a patient is having acne, or अभी हमने manage किया acne for the last 3 months or 4 months, so for this period of time, we have been following up the patient on a monthly basis. Okay, and you were seeing कि हाँ कोई difference अभी आ रहा है. Okay, the patient is responding properly to treatment. जब the patient is going to have a clearing of the entire lesions, then there are some of the complications also. See, regarding the chemical peeling, the TCA and all those things, a lot of peels is coming up these days. Okay, these are usually some fruit-based chemical peeling that is usually being done, or you go for some glycolic acid or fruit TCA peelings, etc. Okay, lot of different types of peeling. But once you're going for a chemical peeling, what you are actually doing is you are removing a layer of the skin. So once you do a chemical peeling, you have to advise the patient that you cannot go into sunlight, you cannot have a direct sun exposure for a few days. It can lead to hyperpigmentation and stuffs. And sometimes just one round is not enough. So we ask the patient to come back to you every 3 weeks, just say every 21 days. The patient comes back and does one more cycle of chemical peeling done. So all those things. Okay, there's a lot of different types of peeling that is available these days. Clear? Chalo. So now when we talk a little bit about the complications as well, what are the most important complications that the patient is usually worried about? हाँ, अभी मेरा फेस में सारा लेशंस क्लियर हो गया, पर काफी ज्यादा मार्क्स है, स्पॉट्स, isn't it? So these kind of spots. So the complication that we are talking about here is about post inflammatory hyperpigmentation. तो वो हो सकता है वन ऑफ द कॉम्प्लिकेशंस दैट इज एसोसिएटेड. अगला जो है, जैसे पोस्ट इन्फ्लेमेटरी हाइपरपिगमेंटेशन जो स्पॉट्स है, for all these spots what can be done is we can ask the patient to use a proper sunscreen during the daytime, and also we can go for skin lightening agents, skin lightening agents. So this can be some niacinamide, azelaic acid, kojic acid, etc. So all these are skin lightening agents which can be used and which will give you a better pigmentation relief. Okay, the hyperpigmentation can go away with the constant use of all those things. Yeah, we can also go for hydroquinone, but not very much recommended, because it can again have its own side effects. You don't want to have such very strong agents that is being used. The other one can be scarring. The other side effect that is usually seen can be scarring. So whenever a patient is having some scarring and all, you can ask the patient to go for some procedures like micro needling. The patient can go for a micro needling, or the patient can go for a fractional CO2 laser. Fractional CO2 laser. Again, there are different types of scar that can be seen with acne. These are called as box scars and all. But whatever it is, so for all the types of scarring, a little bit difficult to deal with the scarring, especially when the patient has recovered from a nodulocystic kind of an acne. Okay, so here we can go for these kind of treatment methodologies like microneedling or fractional CO2 laser, etc. Yeah. So that is all about acne vulgaris. I hope it has been an informative session. And the only takeaway message that I have for this session is I have seen one patient, he underwent TCA cross for scar and came with, yeah, we have to be particularly careful about the procedures that we do, especially the intralesional injections and all. Because when we go for some intralesional injections and all these things, and even for the peeling and all, the patient, there is a possibility that the hypopigmentation can also appear. Because post-inflammatory hyperpigmentation and hypopigmentation both are there. Okay, so when we go for these kind of procedures, hypopigmentation is also likely, but it is not very common. It's uncommon compared to the other presentation that we usually have. Okay, so please remember that whenever you see a patient, please try to have a clear cut understanding कि कौन सा type का acne है, whether inflammatory है, non-inflammatory है, and second thing, please try to understand कि ये mild है, moderate है, severe है, and accordingly please try to have an idea कि आपको कौन सा medications use करना चाहिए. Lot of treatment is available, but always for mild and moderate, always start with a retinoid topical agent, and once it becomes severe, then think about adding some antibiotics and all. And please remember one more thing, antibiotics are never our drug of choice. Okay, the first line agent bilkul nahi hai. The reason is for acne vulgaris, we have to treat the patient for several weeks or months together. So we don't prefer to give antibiotics for such a long period of time. That is why antibiotics, when it comes to acne, is going to be a part of the management. Okay, not the first line of agent. Okay. Thank you so much, Shiv, and sure, no problem. And explore the clinical corner. That is as usual. And thank you so much for being an interactive crowd. So we'll see you again with much more med clinics sessions in dermatology. Thank you for watching. We'll be in touch.